Good evening, one and all. On behalf of Dr. Agarwal's Institute of Optometry, I extend my warm welcome to each every one of you for today's 14th episode of Optometry Series 2.0. Miss Meenakshi, Miss Komati ma'am, and Miss Anshika ma'am couldn't join with us today. I welcome Miss Meenakshi ma'am. Today's topic is lens anatomy and diseases. Now, I welcome Ms. Anshe Banu, third year optometry undergraduate student, to tell us about today's moderator and speaker. Over to you, Anshe Banu.
Hello everyone, I'm Anne Shabana from C18 batch and I'm really glad to welcome you all to today's episode of our Optometry Series 2.0. We have a wonderful session lined up and to lead it, we are happy to have with us our moderator, Ms. Mumtaz Hasima. Ms. Hasi is an optometrist with over a decade of experience in clinical practice and teaching and community eye care. She completed both her bachelor's and master's degree in optometry from Lotus College of Optometry and in pursuing her PhD of optometry in Chitkara University. Before joining Lotus College of Optometry as a full-time faculty, ma'am worked extensively as a consultant optometrist across several reputed eye hospitals in Mumbai, where she gained rich clinical experiences and developed her expertise in specialized area of eye care. For the past 6 years, she has been serving as an assistant professor at Lotus College of Optometry where she teaches optics, contact lenses, biostatistics, and public health. Ma'am also manages specialty in contact lenses, low vision, and myopia management clinics, providing advanced vision care solution to patients with complex visual needs. Her professional interest and expertise lies in specialty, contact lens fitting, low vision rehabilitation, myopia control, and community optometry. She holds the prestigious FIACL, that is, Fellow of International Association of Contact Lens Educator, credential, an internationally recognized and competitive qualification for contact lens educator. Ms. Khasi's commitment to community eye care is reflected in her impactful outreach work and initiatives. In the recognition of her contributions to public health and community optometry, she received the Public Health Award of the Optometry Confederation of India in 2023. We are truly delighted to have her with us today. Please join me in welcoming Ms. Mumtaz Hasi ma'am and our speaker for today's episode is Miss Belesheeya, a third year optometry undergraduate student. Over to you, Belesheeya.
Sorry, but I can't hear her.
Okay.
Is speaking?
Who, ma'am? The speaker. You can't hear
Yeah.
the speaker, ma'am?
Speaker, yes. Belesheeya.
Belisha, can you check your microphone again? Yes, but it is
Final
little
sign
bit
यहाँ
delayed.
को दो और ये यहाँ पे रखा.
Ma'am, can you hear her now, ma'am?
Hello. Hi, Belesheeya. Can you speak?
Hi, ma'am.
Yes, I can hear you now. Thank you.
Okay. Okay. Today's topic is
Sorry, but again, I lost her voice. I can see she's speaking. Yes, I can't hear you.
Yeah,
Can you
Belesheeya,
hear
your
us?
voice is very feeble.
Can you speak again, Belesheeya, please?
Yeah, ma'am,
Yes,
she's
ma'am.
having some issues with her headphone. We are just sorting out.
Okay, perfect.
Hi, ma'am. Now I'm audible.
Yes, very much.
Thank you so much, ma'am. Lens anatomy. Lens is a transparent structure, biconvex, and it's placed where the place depression like a saucer. The equator diameter is about 6.5 mm at birth and increase 9 to 10 mm. Thickness 3.5 mm at birth and 5 mm at extreme age. Weight 65 milligram at birth and I'm sorry, ma'am. Let's start. Uh, Refractive index of lens is 1.39 and refractive power is 16 to 17 diopter. Location. The lens is placed behind the iris and pupil and in front of the vitreous. The shape of the lens is asymmetric. The function of the lens to focus the light on the retina so that the image will be clear. And the main function is to accommodate with the help of zonules at to focus the object at distance and near. Blood supply. Lens is a avascular structure and it gets nutrition from aqueous. Physiology, how it works. Controlled by ciliary body. When looking near, muscle contracts so that the lens become convex more, focusing near. And when while seeing far, the muscle relaxes, lens become flatter. On that, it is relaxing state. Lens disease, cataract, congenital cataract, senile cataract, and traumatic cataract. Cataract. Cataract is referred to a loss of transparency or clouding of crystalline lens, which normally allows light passes through the focus clear on the retina. When the lens becomes opaque, it scatter or block light. It results in blur vision or double vision. It can lead to a partial or complete visual impairment. Accounts of 50% of globally blindness is because of cataract. It is the most common in elder people on occurring due to age. It's because of a genetic UV exposure systemic diseases called diabetes mellitus. It is a major public issue, especially in developing nations. This is an image of normal cataract eye and eye with cataract. There is a difference for both the how the vision will be the cataracted person. Classification of cataract based on etiology, based on sight and maturity. In the etiology, there are two types: congenital and acquired. Congenital is it may be can at birth or at soon as birth. Acquired is because of uh, aging or any exposure due to harmful which is not good to eyes. Based on sight is capsular cataract, cortical cataract, nuclear and subcapsular. Based on maturity, how mature the cataract is affecting the lens. Acquired cataract, which is also known as senile cataract, it's the most common type. Traumatic cataract, due to blunt or penetrating injury, that cataract might become. Complication, secondary of ocular disease, uveitis and glaucoma is also a complication for this. Metabolic,
seen in diabetes or galactosemia. Toxic radiations like UV radiations or ionization radiation are due to drugs for tuberculosis. Congenital cataract, lens opacity present at birth, and then soon after that. Etiology, genetic mutation is mostly seen in autosomal dominance. Other causes can be chromosomal abnormalities like Down syndrome, metabolic disorder like galactosemia, uh, and or infection like rubella while pregnancy or delivery time, or development disorder like aniridia. Morphology, nuclear. In morphological state, in nuclear cataract, the embryonic or fetal nucleus are affected. In lamellar, the involving particular lamellar area. In coronary, brown like brown round like round nucleus. Blue dot cataract is a cat. How its appearance now? It will appearance in blue color on the lens, like dust particles. Posterior polar cataract, central cone shaped opacity is seen. These are the images for the nuclear and choroidal laminar blue dot cataracts. Management in early stage, we in early surgery, 4 to 6 weeks of dense cataract is done. Partial cataract may be monitored so that we cannot do surgery for in congenital areas as people's. Post-operation care, we should take care of refractive errors, prevent amblyopia so that there will be a no partial vision in both eyes. Regular follow-up is both common to assist or manage for the glaucoma or detachment. Visual rehabilitation in a severe stage in case of no surgery is undertaken. Spectacles for older children, contact lens for infants and bilateral aphakia, IOL implantation in infants with cohesion, uh, occu- occlusion therapy to prevent amblyopia. Senile cataract. Senile cataract, also called age-related cataract, is the most common type for acquired cataract. It is generally occurred after the age of 50 years, affecting both eyes, although one eye is usually involved either and more severity. But the age of 70 years, over 90% of individual exhibited with some degree of lens opacities. Etiology, the main causes obviously is going to be aging, genetic factor, exposure to UV, smoking, and malnutrition. Uncontrolled diabetes is the main cause nowadays. The control diabetes and the awareness for diabetes towards the cataract is less. Prolonged steroid uses is also a cause of this. Morphological type. Start with length in morphological types. It starts with a lens cortex, and then it appears lens with shape or posterior subcapsular opacities. Lens become hybrid or solon. Nuclear. In nuclear cataract, it becomes harder. Start in a lens nucleus, clone, and sclerosis. Lens become hard and dense, so that the vision will be also reduced. Etiology of senile cataract. Main is age related. Uh, Due to the age, a senile cataract is present. Modifying factors, it under that heredity, UV exposure, nutritional deficiency, dehydration, and smoking. Pathological, cortical, cortical cataract, decreased protein, amino acids, potassium, increased sodium, hydrogen, and swelling of fibers. Nuclear cataract is in nuclear cataracts, dehydration and compactation of nuclears. High water insoluble protein, pigment deposition, uh, amber, brown, or black lenses seams. Lens become hard, inelastic, loss of accommodation. Oxidation stress lead to protein denaturation in the lens. Lens fiber become compact and lose transparency. Clinical feature, obviously there will be a glare, uniocular polyopia. So the images will be irregular, colored halos on the water droplets, black spots, blur vision, uh, painful progression, vision loss, painless progression. Clinical features. Uh, the halos ring are seen, glare are expected in cataract eye. Signs. Visual acuity is reduced in depends on their severity. It seems in a slit lamp or investigation, colored lens and grayish, purple, milky white, or brown in color. Iris shadows is present. In mature, there is no iris shadows are present. Absent iris shadow while hypermature cataract, and in sclerotic cataract, there is no iris shadow. Fundus glow in a starting stage, it will be a partial red glow, and then in a mature cataract, there will be no white pupil. There will be absent in that, and in hypermature cataract, there is no fundus glow, and in hypermature cataract, sclerotic also, there is no fundus glow, it seems. This is the cataract vision. Depends on their severity, how it actually affected the lens. Slit lamp grading. In grade 1, it will be in soft. The color it appears like white or yellowish, greenish yellow. In the grade 2, it will be appear in, color of nucleus will be in yellowish. In the grade 3, the color of nucleus will be in amber. In grade 4, in brownish. In grade 5, it will be in black or rock hard. Examination and diagnosis. Visual acuity testing. Uh, assess vision loss. If there, how much the cataract is affected the patient's vision. Slit lamp type. What type of cataract is this? In which side the cataract is affected, and how extent the opacity is affected the lens, so that we can easy to surgery. Fundus evaluation if media is unclear. Investigation, IOL measurement, rule out glaucoma, lacrimal sac patent test, so that there will be no risk of infection. Biometry, IOL power calculation, systemic evaluation, so that how fast the IOL is going to shoot, and how fast it going to management. Non-surgical part, we can go for spectacles, protect UV eye from UV rays. In surgery, in surgical type, we can go for IOL, ICCE, and ECCE. Prevention, control diabetes, use UV protection for eyewear, avoid smoking, and reduce the usage of steroids. Complication and differential diagnosis. It may phacomorphic, phacomorphic and phacolytic glaucoma in advanced differentiate from other causes of visual loss like ARMD and diabetes retinopathy. Next one, traumatic cataract. Traumatic cataract is lens opacity following ocular trauma. Can result from chemical, mechanical, or radiation injuries. Common in young males due to occupational or sports injuries. Causes blunt trauma, penetrating trauma, radiation trauma, chemical, and other traumas. Types. Based on type of injury, blunt trauma, which is in the first picture, penetrating trauma, based on how extend the opacity or the injuries happen to the lens, based on time and onset. Some cataract can occur as soon as the injury, some may occur after the years or month. Pathology. Trauma damage the lens capsule, fluid enters lens, and then lens fibers swell and degenerate. And last, opacity forms. In penetrating injuries, lens protein leak causing phacototic uveitis, it leading to inflammations. Clinical features. Glare or double vision are seen. History of trauma may have associated findings, hyperemia, iris tear, corneal scarring, or vitreous hemorrhage. Management. Medical treatment. Treat inflammation and evaluate IOP. Cycloplegic drugs and corticosteroids as applied. Surgical treatment, cataract extraction, ECCE after inflammation subside. IOL implantation if capsule support adequate. Manage associated ocular injuries. Prevention. Uh, Use protective goggles at work or during sports. Handle sharp and chemical materials softly. Seek immediate treatment for eye injuries. Conclusion. Traumatic cataract is a preventable cause of vision loss. Early diagnosis and proper management can restore vision. Ectopia lentis. Definition. Partial or complete displacement of lens, or it may be occur due to trauma or genetic disorder like Morphin syndrome. Symptoms: blur vision, double vision, and irregular pupil shape. Presbyopia. Presbyopia is also normal common stuff for aging people. Definition is going to affect largely in age-related people, loss of accommodation. Cause lens becomes less elasticity with age. Symptoms: difficulty in reading or seeing near objects. Treatment: reading glass or bifocal lens are prescribed. Aphakia, aphakia, aphakic absence of lens. Naturally, lens removed or missing. Cause usually after cataract surgery or genetically. Treatment: intraocular lenses implant, contact lens, or spectacles. Microspirophakia. Definition: lens is smaller or spherical. Associated with Marfan syndrome, effects may lead to myopia or glaucoma. These are the reference which I take to make this present. Thank you.
Thank you so much, Belesheeya. It was a vast presentation on cataract and diseases of lenses. Now I request the moderator to add your valuable inputs, ma'am. Belesheeya, you can unshare your presentation. Yeah, thank you.
Okay, so good afternoon, everyone.
Yeah, good afternoon, ma'am.
Good afternoon, ma'am.
Yes, nice presentation, Belesheeya. As a third year student, I appreciate it was very deep, very concise, Okay. But there are few inputs from my side. See, I like overall presentation and everything. But
Thank you,
next
ma'am.
time, I normally give it to my students also. Don't read the slides.
Yes.
Okay. Because slides is there. Okay. You can just explain whatever is written on the slide. But if you read the slide, it doesn't look good. Okay.
Yes, ma'am.
Can I ask you a few questions?
Yes, ma'am.
Okay. So you have spoken about cataract, right? Just tell me, uh, if you're thinking about cataract, okay, and you have spoken about, say, congenital cataract also, and you said okay, you are going to manage with refractive error and with glasses, with contact lenses and everything. What do you think if you don't correct these kind of patient, then what will happen?
Infection will spread to the neighboring parts, or else the
No, I'm
kid.
talking about, see, you patient was having cataract, you did the cataract surgery, okay, normally the congenital cataract patient, we keep it aphakic because normally we wait for at least 1.5 years to 2 years to get the eye to stabilize. Okay, in between you will give them the glasses, of course, right? So can you tell me what will be the power of those glasses? I can't hear you.
High plus lens, ma'am.
High plus lenses, yes.
Yes, ma'am.
Correct. So high plus lens, what will be the power? So approximately if I'm getting on, say, retinoscopy, I'm getting, say, plus 22. Okay. So what will be your final power for these particular kids who is 5 months old? It's a question for everyone, whoever is listening to your talk.
After doing cycloplegic refraction,
I got
the
plus
power
22, net dilated retinoscopy, plus 22 diopters. Then what you will prescribe to your patient? Because you did such a wonderful presentation, that is why I'm asking.
prescribe 22 diopters.
Plus 22 only. Okay. Anybody else is here? Faculty,
Others will
am
be
I allowed?
joining us in YouTube, ma'am. I'll check whether
Oh,
they are in YouTube.
okay, if
Yeah,
they,
only a
they're
technical
answering
team will
anything?
be in Zoom.
Yes, they are answering anything on YouTube,
No,
on
ma'am,
the
we didn't
comment
receive any
section.
answers yet.
Okay,
No, ma'am, not yet.
not yet. Okay, but I can ask, right, this kind of questions?
Yeah, ma'am.
Yes.
Yes.
Okay, so ideally, not only cycloplegic refraction, it is just for the learning thing. Okay, we normally add plus 2.5 or plus 3 for the aphakic glasses. Because if you talk about the child who is just 5 months old, their major work is only for near. So we have to work out for the accommodation as well. So instead of plus 22, you are going to prescribe a patient plus 25 diopter glasses. And if you are going to provide contact lenses, you have heard contact lenses, right? We have aphakic contact lenses. So you will prescribe plus 25 or you will prescribe something else? For glasses. This is very important, guys. There are a few more questions. Maybe I will get back to your faculty and you can understand. One more thing I have to ask you. You have very nicely talked about the different types of, say, ectopia lentis also. And you have mentioned about Marfan syndrome. So can you please tell me what type of dislocation you see in Marfan syndrome?
Supronasal, ma'am.
Sorry, superior nasal.
Yes.
Okay. It's temporal. Superior temporal. You're on mute. It's temporal. And there is one more syndrome which where we see normally just opposite of Marfan syndrome, where we see this ectopia lenses very commonly.
Marchesson syndrome.
Yes, wheel matches, and very good. Good. So overall, this is very nice. Okay. You have focused on something which you like. Okay. Before, I just wanted to add, before we used to do something called as ECC or ICC or something. We used to do something called as SICS also in cataract surgery, which is small incision cataract surgery. Before phaco, we used to do something called as small incision cataract surgery. This you could have add on. And one more thing. Okay. When you are talking about those cataract patients, no, when you are talking about different types of cataract in your starting few slides, if you could have just put the images over there, so it will be more easy to understand. You have put it, but you have written all the theory together and all the images together. But if you write individually, it will be more beneficial for the someone who is trying to understand your talk. Okay, but overall, I like your presentation.
Thank you so much.
Thank you so much, ma'am.
Yes.
From students' perspective, there are a few questions alone. I'll read it out for you.
Yes.
First question is, when do we advise cataract surgery for senile cataracts, ma'am?
For senile cataract, see, now normally, initially, if you see, we used to wait for say grade 3 or grade 4. Now, but because we have a newer technologies like phaco and everything, people who are into grade 2 also, they can go ahead. See, we avoid doing only for nuclear sclerosis, but for grade 2 also, we can go ahead with the cataract surgery. And if patient is saying that their vision is getting blurry, it depends upon the symptom, we can go ahead. The next thing what we can do is, it depends. See, if you see in case of nuclear cataract, okay. So in nuclear cataract, you normally see something called as myopia shift. Okay, patient will be maybe +1, +2, but suddenly you will see on retinoscopy, you are going to see -1, -2, or -9. Then on the basis of that, you can decide for the surgery. So it's all about symptomatic of the patient and then of course the slit lamp examination. So both will go hand in hand.
Thank you so much, ma'am. The next question is, what kind of management or investigation should the optometrist concentrate about the cataract?
Yes. So of course, it's a yearly follow-up is very much required. Once you are done with the yearly follow-up, but if you are now confirmed the patient is going to go under the cataract surgery, then as she has mentioned in her presentation also, there are battery of tests which we need to do. We have to first start with your basic vision refraction. I always tell my patients to, or always tell my interns to do the pupil examination as well. And because we do have something called as retinoscopy and direct ophthalmoscopy in hand, so they can perform those tests. But apart from that, the basic cataract workup, see, it depends what type of IOL you are going for. It is very important. See, nowadays, you get to see n number of monofocal IOLs. You get to see spherical. You get to see something called as toric intraocular lens. You get to see something called as eye hands. So the battery of test will be little different. But ideally, we should know how is the condition of the eye, what type of cataract is there, grade of the cataract, and then what is the retina condition. As she mentioned in her presentation also, okay, one thing you have to look for the media. See, sometimes because the cataract is so dense, you cannot see what is happening in the retina. Then we advise patient to go for something called a B scan, which he has mentioned briefly, where we can just understand okay, what is the status of retina, whether it is attached, not attached, or how the optic nerve is functioning. But apart from that, you have to do A scan. If you can do it, if you are on the campsite, you can do A scan. If you are on the hospital, if your hospital has IOL master, better you do IOL master. Then one more thing you can add on, if you are going for high-end, say suppose toric IOLs, so you need to do something called as pentagram to understand the corneal topography, to understand the abrometry. Here in my hospital, we normally do something called as OCT also to understand the macular function. So it depends upon patient to patient, but one thing is which is universally which we accept, your vision, refraction, slit lamp examination, fundus examination, your basic axial length measurement, because we have to calculate something called as IOL power. Now we are not doing anything which is aphakic cataract surgery. Everybody we are putting IOL, except the few infants, but in now we've put the IOL for 5 months old baby also. So we have to do it. But only the condition is if it is a young adult, you can do it normally. If it is an infant, say 3 months, 4 months, so every examination will be done under anesthesia, EUA, examination under anesthesia.
Thank you so much, ma'am. That's all with the questions. Now,
Yes.
Anshi ma'am had joined us.
Yes.
Ma'am, are you there with us?
Yes, hi.
Hi, ma'am. Do you have any questions for the moderator, ma'am?
No questions I have. It was a wonderful session, I think very detailed by Belesheeya, and thank you, Mumtaz, for adding all your points. It was wonderful. I know lens is a very small part of the eye, but very important, and that's the place where the optics pass through, and then we get the visual. So
And
thank
where
you
the
so much.
optometrist can work.
Yeah.
There are so many people. I always say that when there is something called as, especially the pediatric cataract, okay, the congenital cataract, where optometrists are the only one who can save patient from going under like aphakic glaucoma, who can save nystagmus level. It's a very important. If you don't give them a proper correction, don't do a proper retinoscopy, they can go under nystagmus, amblyopia, and then you cannot take them back. Whatever you do, you put a very good IOLs also, but you cannot help them. But if you just do the proper workup, proper simple retinoscopy and best prescription, you can save patient's life.
Yes, so that is very, very important. So thank you so much, Mumtaz, for your inputs. Over to you, Sandhya.
Thank you for joining and moderating today's session. Can you hear me now?
Your voice is
Your
little
voice is
breaking.
very feeble. Yeah.
Mama?
Better.
Now it is better, ma? Yeah. Thank you for joining and moderating today's session, ma'am. We'd like to host you on the another wonderful platform. Thank you so much, ma'am.
Yes. Thank you.
Dear audience, the announcement for this week is admissions for fellowship and pan-India internship in optometry is open. So the contact details are given in the description box. So please check it out. And I would like to thank you all for your continuous support for our optometry series. So if you like this video, give a thumbs up, share this video, and I will see you in the another episode. Thank you. Bye bye.